The nursing documentation is very important in the NICU, and the NICU flow sheet, which includes entry of vital signs, the ventilator settings, the fluid chart, and so on, and their regular notes, which includes the handover notes, regular progress updates where they mention changes in the baby's care, and important checklists as per the care bundles, pain scoring, and other tools used. They also have to acknowledge the physician order as they are carried out. It can be time consuming, and it's very important to stay organized, to be on top of things. Sometimes you may struggle, especially if you are new to a unit, so you should take help in how to improve one's organizational skills so you're not overwhelmed by the clinical work as well as the documentation, both of which are important. But clinical work always takes priority. Of course, we need to complete this, otherwise you'll end up going home late, so better to get organized with that as well. The flow sheet is a very important document. It can be in the electronic medical record, but many units still have the paper form, and typically because it's a large amount of information to be entered, they have the A3 sheet for the NICU flow sheet. It includes daily assessment details like current weight, change in weight, intake, output, vital signs, the ventilation details, blood glucose, bilirubin, acute events, venous access, intactness of the venous access, and so on. It's very important to fill it in real time. It should not be a same value repeatedly as you look like it's cooked up values. So always be clear, always put it in real time. And if there is any abrasion or any vital sign out with the range, it's like the newborn early warning score, you have to inform the physician. Of course, the NICU team is fully versed with this, and they would call for help as soon as they think something is not right. So this is an example, the sheet we use in our unit. I'll be going into sections in detail, so don't worry about reading this big sheet. This is one part of it, and this is the breakup of this. So we have at the top the date, the age of the baby in days, birth weight, current weight, whether the baby is intubated, then the size and the length of the lips. These are important information, and this should be revised whenever the baby gets re-intubated. Intake and output is a summary based on what we will see next. The day nurse and the night nurse, and we would be using abbreviations in between, and you mentioned these initials alone so that you don't need to write in a small chart all the information. So if you put plus, it's agreed, mild, moderate, severe. P for pink, double P for pale pink, PL plethoric, J jaundiced, motile, cyanotic, G for grunting, R for retraction, S for shallow. So this is for the respiration and the appearance of the baby. Then the OG tube, again you mentioned incubator change date. Most units change it weekly. Umbilical arterial lines, UVC central line, and insertion date as well. So this reminds you to check their necessity on everyday basis during the rounds, which is good practice and is included in most care bundles. If the baby is on TPN and also feeds, when it was started, how it's progressing, whether the newborn screening is done, and remember preterm babies do need a repeat newborn screening. You can review my video on screening in preterm babies, and the ROP. So this acts as a reminder for these. And this portion of the sheet is for infusion, so the time is written downwards. Infusion fluids, you may have multiple infusions, so you have 3 columns like this. Infusion fluid, I have just taken 2 to show you better. The rate, the total that's going through at each stage, the pressure reading to make sure there is no obstruction or occlusion, IV line change if it was done in between, IV site check. So this is part of the IV care bundle as well, that we to avoid extravasation and also infection prevention, and the initial of the person who is recording it. So at the bottom of the page we have the grand total of IV fluids in ml per kilo per 24 hours as well, and again a review of the output from the intake from the IV access, then any output from the drain, Foley catheter if urinary catheter is there, ileostomy, colostomy if they are applicable, and GCS only if there is any concerns. Here we mention about allergies, mostly it's not applicable in newborns, and the provisional diagnosis and the primary physician are there because it's a daily sheet, and the nurses sign at handover as well. This is the back portion of the sheet, and again, as I will come to it, it has sections for blood gas, ventilation, observations, where we write the feed part as well, and assessments. So this is the blood gas section. So we have the vital signs recorded as well, and according to the time, temperature, heart rate, respiration, saturation, blood pressure. This is the mean blood pressure and the systolic. Pain assessment, NIP scoring, blood gases, if they are done, you enter it here as well, and we do get the reports in the system. When we are on ventilatory support, the mode is selected here. Volume guarantee, what is the ml per kilo you are setting. Tidal volume, that's actually measured. PIP, PEEP, set rate, trigger breath, inspiratory time, IE ratio. So remember that if you make any changes, you need to inform the nurse, so when they do it next time, they would update it. Sometimes it gets missed out if you don't communicate, so it's a responsibility of whoever is making the change to inform. If it is high frequency, you need to write the settings accordingly. The FiO2 is important. Humidifier, it's always important to make this in the hourly check as well. So you check if the water is running out, you would fill it. And if the baby has suction, endotracheal, oropharyngeal, you would enter it here as well with these abbreviations. The observations include incubator temperature, incubator humidity, air entry, presence of recession, skin color, check for the nares to avoid injury, blood glucose in milligrams per deciliter. If there is any gastric aspirate, the urine output is measured here. The stool output is entered here, and positioning is important to rotate the position as possible. The feeding is entered under this part, so this will be added with the previous page, IV fluids and TPN, and then you would get the total intake for the day. Of course, this setup, depends. You may use a different chart, and the feeding may go with the IV part as well on the same sheet. Alarm limits. This is a reminder that you need to look at the alarm limits on everyday basis at every shift change. Sometimes we individualize the alarms. Most of the time the unit has specific alarm limits for gestation base and sickness level. So you follow that as well. So we have abbreviations on the right hand side of the sheet as I discussed in the beginning. So if you are entering under the suction column, these are the short forms. In the temperature column, if you put these observations, these are the short forms. And saturation, if there is a probe change. Air entry, if you are listening to the chest, this is what you mean. And positioning, supine, lateral, prone, so changing in position. So this is just a summary of the NICU flow sheet, and as I said, go through the sheet you use in your unit so you get a clear idea of what's happening. The next important documentation, in addition to what we discussed earlier, is the handover. Both physician and nursing handovers, better it is done on the SBAR format. Both the teams can share the handover sheet, it can be updated together, and then they individually hand over and endorse. So the SBAR format is used, situation where you include demographics, name, hospital number, weight, gestation, gender, bed space, etc. Don't ever refer to them by the bed space, it should always be by the full name and the hospital number to confirm patient identifiable information. The background would include a history of the baby and the main events till now. For example, if you're talking of respiratory distress, we can say baby had RDS with 1 dose of surfactant by Ensure, received NIPPV for 5 days and has been on high flow since. This is a short summary of the respiratory course, and like that for each system you would enter 1 or 2 lines. The assessment would include the recent review, investigations, imaging, procedures and everything in the past 24 hours or in the previous shift especially, and the response would be the current and pending plans, the plan for transfusion, plan to stop antibiotics, plan for cranial ultrasound, etc. So this is again a portion of the SBAR chart that we use for the handover for individual babies. We also have a full team's SBAR sheet where this is summarized. So this would include the situation part which I discussed. So the gestational age, corrected age, birth weight, current weight and change in weight. date and time, Apgar score, baby blood group, mother blood group, and so on. The background part would cover the different systems, respiratory, cardiac, what support they are getting, cranial ultrasound, echocardiography as done, and you'll have a short history of the problems as well. And then assessment would include central lines, whatever fluid is going through that. This is also part of the background actually, because it's about reviewing the lines. The assessment would include the nutrition that the baby is getting, IV fluid that the baby is getting, feeding, the OGT, urine output, bowel opening, and so on. And the final part is what response or action we need. So the name of the medications, whether any test screening is due, and if that has been done, any lab results which are to be collected, and then you mention it. If there is any transfusion, if the baby is getting discharged, you would mention that as well. So obviously the person giving and the person receiving should both sign, and it should be documented in the file. The final part is about refusal of consent, reporting of incidents, and miscellaneous parts. It's very important to document in the appropriate form if a significant treatment like a lumbar puncture is refused, or if the parent insists on taking home without phototherapy, for example, where it is indicated. If it's a really difficult case, like the baby is not really ready for discharge but the parents insist, it will be against medical advice forms, and you need to escalate to your senior in these cases. Each hospital should also have a clear system to report incidents. Incidents can be in any aspect of the care. It can be extravasation, it can be self-extubation, it can be a parent who is angry with the staff, it can be a staff member who is angry with another staff, it can be a needle stick. So we should encourage a culture of safety, and reporting incidents should be for improving the quality of care provided within the unit. So it's a system, and we shouldn't have a punitive response, so this will encourage people to report it. We can discuss incident reporting in a separate topic. In addition to the above, drug prescribing is a separate aspect of documentation. It's very important, very critical. We have to do it carefully. I have discussed some of the details of how to prepare infusions, but we can do one on prescription as well later on. So medical documentation is a permanent record of what we do in the NICU. We should pay attention to ensure it really reflects the hard work we put in. Very important to put particular attention to discharge summaries, transfer notes, as they have immediate as well as permanent impact. And remember that the parents often read thoroughly through that. So any specific diagnosis that is not relevant, you can remove it, which is not confirmed, I mean. We should be aware of the medico-legal implications of our documentation. So not only is it a matter of pride, it's also a future implication if you don't document properly. If you are working as a team, feedback to each other if you find mistakes so we can improve constantly. Don't take it in a wrong way, because our feedback is purely to make us do better. Avoid abbreviations unless it's approved in your unit. We may have a list of abbreviations that are approved, and better to avoid totally in discharge summaries and consent forms. Mainly because the discharge summary is often going to others who may not know your approved list. And where notes are handwritten, pay attention to good legible handwriting. This is of course easier said than done. This is a very important topic, and I hope it helps. Do share with your colleagues.